Hey everybody, I'm Stephen Dorner. I'm here with Elaine Goodman, and we have an opportunity to talk to you today about the new COVID virtual observation unit and consensus guidelines around the management of patients in the outpatient space with COVID. Elaine, how's it going?
Great, thanks. How are you?
Doing well. So excited about the launch of the new COVID virtual observation unit this week. We've started enrolling patients from inpatient spaces, from the emergency department, and from the RICs who are isolating at home with COVID, giving patients an opportunity for them to report in on their symptoms and have an escalation arm for any concerning features about worsening symptoms where paramedics can be dispatched to evaluate patients in their own homes with virtual visits supported by emergency medicine attendings to really determine if patients need a higher level of care or if they're safe and stable to continue isolating at home. Been working in the with the RIC teams to get this launched, and we've also incorporated some of the new consensus guidelines around where patients can best be managed for their appropriate symptoms. Elaine, could you talk a little bit about the new consensus guidelines?
Yeah, absolutely. And I'll just start off by saying we're really excited to have this resource available to our patients who go home from the RIC. It's definitely been a source of frustration for all of us to not have that many options to offer people. And so this is a great program to have launched this week. So the consensus guidelines were revisited recently by an interdisciplinary team of folks from across the RIC, broader primary care, the emergency department, inpatient, and ID to really think through, given what we've learned over the course of the pandemic so far, who is best served by an ED visit versus an inpatient stay versus going home. And so I thought actually that before I dive into how we are thinking about these in the RIC, that it might be great to hear from you, Stephen, about how your thinking has changed on the emergency department side for which patients get admitted and which are sent home, because I know that that's not exactly the same as it was back in March, April, and May.
No, you're totally right. When during the first surge in the spring, we were really limited in terms of our therapeutics and the knowledge that we had about this virus. And over the last 10 months or so, we've learned so much more. We've learned that even mild hypoxia really can cause ARDS development, that administering dexamethasone can help a lot with these patients in tempering the severity of their disease. We have remdesivir, we have BAM now, we have different therapeutics. And so we have a better arsenal at our disposal. And we've identified that if patients have oxygen saturations that are at 93% or above, if they don't have any other concerning features, they're fine to be isolating at home. But the new virtual observation unit gives them a way to report in on any worsening symptoms with the hope that this is going to decrease the burden on the PCP clinics, all the other outpatient clinics who are working desperately to monitor these patients, and take that onto the part of the virtual observation unit, so that our team of monitoring nurses and our emergency physicians working in conjunction with the paramedics will be able to better monitor these patients at home and give them a way to be evaluated without them overwhelming the emergency department.
That's great. And so based on now that we have a good understanding of the current practice in the emergency department for these patients, in the RICs, we're using basically the same cutoff, an oxygen saturation of 92%, for example, or any really clear respiratory distress when they present to us is going to go straight to the emergency department. When we think about referring to the virtual observation unit, we're really thinking about those other patients who come to the RIC who end up being COVID positive. And of course, the people that we are most concerned about in that category are those folks who have oxygen saturations of 93 or 94%. They don't qualify for supplemental oxygen necessarily, but they still don't have a normal O2 saturation. And then, as everybody knows at this point, those high-risk comorbidities or older age that put them at risk of progression of COVID-19, those are the other patients that we're really hoping will want to enroll in the virtual observation unit. And these full criteria that have been developed are going to be posted in a number of places. For my primary care colleagues, they're going to be on PCOI. And the criteria that we're using for age and comorbidities is the CDC criteria, which you can also link out to from the full text of the guidelines. One of the things that I know has already come up, Stephen, in the primary care community is what about patients who are at home who call into their PCP's office? How would they access the VOU?
Yeah, so right now we're currently enrolling patients out of the inpatient units, the ED, and out of the RICS, so that we're making sure that we're capturing patients who are having symptomatic COVID and prioritizing their enrollment. We're looking at other areas across the institution because so many folks are interested in having their patients enrolled. It's important that we be able to have the enrollment workflows within certain ordering departments put in place so that we're capturing the right patients and make sure that they're enrolled appropriately. So I would say if you have a patient who hasn't yet been evaluated in one of those enrollment areas, stay tuned. We're coming to you soon. Please reach out with any questions about how we can best support ordering patients for enrollment in your area. But it's on our radar. It's something that we really want to expand across the institution. We're just brand new and getting our feet under ourselves, and we're excited about all of the developments that have happened really quickly in this space.
Great. And I'll just add that in these guidelines, there are also guidelines for which patients are fine to stay at home versus coming into the RIC if you are getting calls from those patients. They're not different than what is already in the COVID triage smart phrases and radio buttons that you're using in Epic, but they do incorporate oxygen saturation since we're seeing more patients who've purchased those monitors at home, or you may have patients who enter into programs like VOU and get an oxygen probe through those programs. So again, the big broad brush guidelines here are SATs of 92% should go to the emergency room without waiting for a RIC appointment. But for others who are in that middle category of 93 or 94%, particularly with comorbidities, those are the folks you can send our way to the RIC, and then we can enroll them in the VOU if that is warranted once we've seen the patient. Anything else you'd like to add, Stephen?
No, if you all have any questions about the program, please don't hesitate to reach out to us, or questions about the new consensus guidelines. We're excited to launch this program and try to better support our clinicians and the patients during this trying time. So thank you all for your help and cooperation in this space. And it's been great working with you on this, Elaine.
You too. Thanks so much for helping getting this going for our patients.
Thanks.